And thank you so much for having me, everybody. I'm going to spend a couple minutes kind of filling in for some of the talks that we had, which are obviously excellent on the setup for deformity, especially in spine tumors. As a learning objective, we'll identify some common causes of deformity in spine tumors and some strategies to deal with these intra-op and post-op disclosures. So in terms of spinal deformity and neoplastic conditions, a lot of these are secondary to collapse of the vertebral bodies that we've seen before. Except for the upper cervical spine, most of these are translational, most of them are kyphotic in nature, except in the upper cervical spine where they can be translational and rotational as well. And on the left here, you see a picture where we have some focal kyphotic deformity, which is the most common cause, the most common presentation of deformity in the cancer population. Kyphoscoliosis can also be seen in the chest wall, meaning like not just like proximal kyphosis, but also coronal deformities, especially if it involves the chest wall, unilateral pedicles, ribs, and so forth. Anterolacesis and posterolacesis may also be encountered, but these are also more commonly present when the posterior elements are involved as well. One thing that's very important with these deformities, they're very flexible. They're a lot more like the pediatric population than they are the adult degenerate population, which are very rigid in nature. These are some examples also of the kyphotic deformities on the left in the upper thoracic region, which you can see about 20-30 degree focal kyphosis from loss of anterior height, which is a very common presentation for these metastatic diseases. And then in the cervical C4 body, we have some retinoschisis and kyphosis as well. This is a more drastic example of a deformity. We have about a 90-degree curve with a sagittal imbalance from a complete loss of not one but two bodies, and with splaying the posterior elements, which we'll touch later, can be reduced with several maneuvers. We had some excellent talks about the SINS criteria during this course already, but just to remind everybody that spinal alignment is one of the criteria, with subluxation translation being high, giving high points 4, but deformity scoliosis is given a point of 2 as well. Just as a reminder to everybody, I'm sure everybody here knows these parameters, but I'll just go there kind of quickly. Our body in the end is made to stand straight with about a conus of economy. We can shift in the anterior, posterior, lateral zones to a certain degree, but once you exceed this conus of economy, that's when the quality of life measures start to decrease and patients start to experience significant pain. There is a relationship which has been demonstrated within kyphosis, lordosis, pelvic incidence, sacral slope, with these parameters needing to be within certain limits for the patients to be neutral or fairly well aligned and to maintain their quality of life measures. There's much more and more data coming out, and some of this are more widely accepted, that similar relationships can be established in the cervical spine with the C2, C7 sagittal balance angle, as well as the C2, C7 angle, the pelvic tilt and T1 slope being kind of critical to kind of maintain a cervical balance. For patients with metastatic and oncological diseases, there are some papers published, and it has been shown that patients with positive sagittal balance often experience, especially with cervical spine tumors, decreased quality of life measures with significant neck pain, radicular pain, and just in general unhappiness. It's particularly related to pain and functional outcomes. It has been shown that with a higher C2 positive balance, they have poorer and poorer quality of life metrics. And with the C2 to 7 sagittal balance angles, of which are 40 to 50, results in worse clinical outcomes pertaining to neck disability index. This all means is that, even the more imbalanced the patients are, the more you can imagine that they're going to have pain, have a pretty poor quality outcomes pre-op, but also post-op. As we know, patients can compensate for some of these metrics, say with pelvic intervulsion, hip motion, knee flexion, but the more they have to compensate for these, the more discomfort they can also start having secondary in these other hip joints and knee joints. The ideal relationship of lumbar lordosis is plus minus 9 degrees from the pelvic indices, and a T1 slope and C2, C7 lordosis about 26 degrees or so, which corresponds to positive surgical, more than that, misalignments, and thus worse cervical outcomes. This is just to show that not everybody's built the same, so having different pelvic incidence will affect the overall balance of the spine, with a higher pelvic incidence needing higher lumbar and at times thoracic kyphosis and lordosis to compensate for the incidence as well. In terms of correction maneuvers, there's really four key elements that we can use. One is positioning, one is cervical traction for upper cervical deformities. One is the expandable hardware. We've seen a lot in the courses and the labs today, and of course, instrumentation. Just by positioning alone on the table, patients can actually reduce in an average about 6.5 to 4 degrees of reduction. Placing of the hip pads, chest pads, arms, and so forth can actually really have a significant impact just on the alignment of the patient, because these are very flexible deformities, as we mentioned before. Cervical traction can be very, very powerful, especially in this upper cervical region. Placing weights, about 5 to 10 weights to start, and then 10 per level can really help align the spine in a more neutral position. Of course, positioning your pins can be actually help as well when you're placing these, kind of induce either flexion or extension appropriately. Expandable cages, which we spent a lot of time talking about, are very powerful as well. PEEK implants, titanium implants, and so forth can really can overcome the deformity that the patients have and bring them more to a neutral position. And open reduction with pedicle screws, reduction rods, and reduction tabs can also help with the induced proper alignment. There's a lot of different techniques, which we spent a lot of time about. In general, contouring your rods and pushing your spine, and cantilever techniques can really reduce and return some of the imbalance with osteotomy as needed. As I mentioned before, these patients, because of their flexible nature, often require less of the osteotomy to reduce into a more neutral position. In the end, what we want is to, even though, of course, our main goal in a lot of these patients is to return them to a more neurological good standpoint and to get them to their second stages of treatment, being radiation or chemotherapy. As tumors, their prognosis has becoming longer and longer. We do have to keep in mind these pelvic, these sagittal parameters, and to try to aim as much as possible to keep them in good alignment, and because of some of these patients now are living like 5, 10, 15 years. So if keeping the quality of life metrics can be severely affected if they're misalignment without a significant positive balance. Kyphoplasties and vertebroplasties, they actually also, at least from the literature, they can show that they can actually improve some of the lordosis and kyphosis. So reported about 2 to 5 degrees can actually be returned with just kyphoplasties themselves. Here's an example of a kyphoplasty procedure where, like I said before, just positioning the patient on the table, you get your 5-10 degrees or so from the mobile segment. And then by the cement, creating a more rigid construct, you can kind of maintain that new alignment post-operatively. Just some 2 quick cases. This is a 57-year-old female with a new diagnosis of non-small cell cancer presented with worsening back pain and balance. Had pretty significant kyphosis, a lot of focal pain, as well as stenosis, for which we perform separation surgery with a corpectomy and cement placement with a more return to a neutral alignment and improvement of her pain. And another 63-year-old male with unknown primary presenting with a nursing and neck pain with a C12 rotational listhesis, and for which we performed an occipital cervical fusion. In short, deformities and metastatic disease are usually kyphotic because of the collapse of the anterior elements. They're usually flexible, even though traditionally we have concentrated a lot on separation of the elements and getting the patients to their secondary stages of treatment. I implore the audience and people that as patients live longer, that we should really keep an eye on these spinopelvic parameters, because the quality of life metrics will be severely affected, let's say, if they're post-surgically or misalignments. Thanks, everybody.
Thank you, Louis, for showing us and pointing out the intricacies of this problem. It's not well published, and you've helped us greatly look at some of the parameters. So adjuvant fixation, we all know about cementing, but sublaminar cables, hooks, do you do anything to kind of stabilize these spines to make a deformity correction easier and more lasting? Share some of the technical tidbits that you know and that you can employ in order to make this fixation work better.
Yeah, no, I think that when we are doing our surgical planning, a lot of times we do use either software or we radiographically we try to aim to be able to return by different surgical techniques the patients to a more neutral alignment. They're so flexible that as we've talked before and as we've shown in the core cadaver courses and some of the previous talks that with adjuvant instrumentation, either the corpectomy cages, cantilever techniques and positioning, you can achieve significant reduction of their kyphosis and return them to a very more neutral alignment. All the armamentarium that you mentioned is extremely useful. I think pedicle screws have become the mainstay for a lot of these because of the ability to cement, augmentate, allow them to fenestration to kind of make sure that they don't fail with time, especially in this particular population. But having the ability to have your hooks, either laminar hooks or TP hooks or pedicle hooks available, or wiring translaminar labs, especially the destruction of the metastatic disease, for example, has taken place, is extremely useful. They're strong. I mean, I like from my experience, those hooks can really support the spine, and sometimes they can minimize some of the dissection, especially in the upper cervical, lumbar, or thoracic regions. So I think we've gotten pretty used to using the screws because they're pretty strong, and you can pull hard on them to kind of get them back, and you have that defenestration ability. But for sure, you should have those hooks and wiring available in case you can't place them.
Great stuff. And Dr. Gokazan in the lab commented that he likes to put split fibular allografts posteriorly on the lamina and cable those down. Do you do anything like that to kind of help these compromised patients get some bony healing? What did you think of that suggestion? He's offline, so you can use him freely.
Yeah. I mean, I think that it definitely can provide some support. In some of my experience, I've seen some of them not fully fused. I've ended up taking one of them out. Some of the fibular grafts post-op for it was just gonna hang out there. I think you do meticulous decortication and putting your bone graft can be extremely useful. Like you guys mentioned before in some of the other talks, like if you are putting cages, packing them with allograft and DVM can be very, very, very important, especially in the patients that you're expecting them to live, a year, 5, 10, where you really want them to get to fuse. It's very challenging to get them to fuse just because they get radiation post-op, and the quality of a lot of these patients are older, so the quality of their bone is already a little bit compromised. I don't use a lot of the field grafts. I've used it a couple times. As I mentioned, I had to remove one, didn't fully fuse, and the patient was complaining about it. But I'm interested to see what other people think.
Yeah, unresolved issues still, but very nice talk, beautiful pictures, and very thought-provoking issues. So we should definitely focus on that much more. In the interest of time, thank you so much, Dr. Kolb.
Thank you so much for having me too.